Good morning to everybody and Happy New Year. I hope everyone enjoyed a peaceful and, for those not on call, a restorative holiday season. We're getting started with our spring semester, and with the wonderful help of Dr. Weininger-Cohen, are excited about our array of lecturers. And we're particularly excited today as we kick off the spring semester to have Dr. Javier Zulueta with us. Dr. Zulueta is currently the director of Pulmonary of Navarra, also an associate professor at the University of Navarra School of Medicine, all in Pamplona, Spain. And he is the recent former chief medical officer of VisionGate. Dr. Zulueta received his medical degree from Complutense University in Madrid, and then completed an internship and residency in the Case Western University system, followed by fellowship in pulmonary and critical care medicine at Tufts Medical Center in Boston, and also a research fellowship at Tufts. And subsequent to that, started off his really productive and wonderful academic career at Tufts as well. Most notably for us, Dr. Zulueta, come June, will be our new chief of pulmonary critical care and sleep medicine at Mount Sinai Morningside. And it's a culmination for us of a couple of years of getting to know Dr. Zulueta and really following on some very substantive work that he's done with colleagues in the system. For example, helping to write some of the most important guidelines for screening for lung cancer, with people like Juan Wisniewski in the System Department or Division of General Internal Medicine, and then Claudia Henschke as well, who, as everyone will know, has been a leader in lung cancer screening. Javier, even prior to arriving, has developed great relationships with some of our folks also focused on lung cancer screening, like folks in radiology, and has a longstanding relationship with some of our pulmonary colleagues. He's done wonderful work in Western Europe and the UK, really helping us to broaden our understanding of who's at risk for lung cancer and how we should be screening them. We're all familiar with doing what I've learned from him is really a one-dimensional evaluation of patients related to their tobacco history. But he's done so much through his publications, through his work with organizations like the International Association for the Study of Lung Cancer, where he chairs the Screening and Early Detection Committee to broaden, as I say, our understanding for who's at risk and how best to get them into care to avoid long-term complications of this very, very serious disease. Dr. Zulueta, we're thrilled to have you today. We are very much looking forward to welcome you in person in the coming weeks, and welcome.
Thank you very much, Samuel, and thanks for the invitation to present at this inaugural grand rounds of the semester. I would like to also, I wish I could be there, but I'm looking forward to, in a few weeks, meeting you in person. Of course, if, as we were just talking about a while ago, COVID allows us to someday resume our, I was going to say normal lives, that's probably far away, at least pseudo-normal lives. In any case, I've been asked to talk about the work that I've done and I've been involved with, which is lung cancer screening, and I'm going to try to do that over the next 45 minutes. These are my disclosures, as has already been mentioned. I'm a former employee of VisionGate, which is a small biotech company that develops products that might be in the future involved with diagnosis of lung cancer. I'm going to talk very briefly about the problem. I think we're all aware of it and we all know it. And then I'm going to do a review of lung cancer screening, look at the history of it, the current status. I'll touch upon controversial points, and at the end I will talk a little bit with a couple of slides about the future of lung cancer screening. This special issue of the US burden of disease looked at a long period of time between 1990 and 2016, and they looked at many metrics. I'm going to focus on disability adjusted life years, which is actually the sum of two other metrics, the years of life lost and the years of life with disability. And when we compare these metrics in 2016 versus 1990, you can see that the top four causes of dailies are very similar. Ischemic heart disease and lung cancer remain as the number one and number two. COPD has jumped from number 4 to number 3. So these three first causes of disability adjusted life years are going to come into play later on in the talk when I talk a little bit about the future, and I'll mention this again later on. But we know what the problem is. The problem is lung cancer. And I'm sure you're all aware of the SEER database, which is a registry of lung cancers that has collected, of cancer in general, I'm sorry, that has collected data way back from the 70s up until now, and shows a very good picture of the situation of cancer in the US. And we know that lung cancer, the incidence of it and its death rate is dropping quite significantly since the 80s. It peaked in the mid 80s. And because of tobacco control, most likely, these rates have been dropping steadily ever since. And this is across all ethnic groups. However, it's still a big problem, and it's going to remain a big problem for many years to come, probably decades to come. In the year 2020, it is estimated that lung cancer caused about 135,000 deaths, much more than any other cancer, representing about 13% of new cases in the US in a year. Now in Europe and in China, the problem is even worse, probably because of tobacco control, which has not been as successful and also has started to be implemented much later than the US. All across Europe, this is beyond European Union, we're estimating about 388,000 deaths per year. And in China, over 600,000. Around the world, we're talking about probably 1.5 million deaths per lung cancer, from lung cancer per year. So we have a big, big problem. And the reason is shown in this data from this year. You can see that 2/3 of cancers today are diagnosed in stages 3 and 4, stages in which you cannot cure cancer. Only 17%, this is the latest update of this data, 17% of lung cancers are diagnosed in stage 1, which is the stage in which we have high likelihood of curing a patient if we can resect surgically that cancer. And if you look in the graph below, the 5-year survival rate by stage of diagnosis is clearly what determines these very bad statistics that I just mentioned. If you're diagnosed with a stage 3-4 cancer, the chances of living 5 years is less than 6%. And why does this happen? Why is this the case? Because we know that there are early detection programs for many other cancers, and they're very good treatments for many cancers, even in advanced disease. Well, the 5-year survival, the overall 5-year survival in lung cancer is 20%, which has been an improvement if we compare it to 7-8 years ago, when we were talking about 15%. And this is probably because of the improvements in treatments of advanced stage, but still we cannot cure cancer in advanced stage. So why don't we have better numbers? And the reason is we do not have early detection programs. And I hope that by the end of the talk, if you don't know it already, you agree with me that this is something that is difficult to understand, knowing the data that we have today. This slide that I'm going to show a couple of times or 3 during the talk is a non-scientific graph. It's just, it plots the number of publications every year, publications in which lung cancer screening appears in the title. So, probably misses a lot of publications dedicated to lung cancer screening, but it gives us an idea of the interest in lung cancer screening since way back in the 70s. Back then, some big trials were done, sponsored by the NIH, looking at chest X-ray as a tool for lung cancer screening. and they failed. They failed to show a reduction in mortality. These were randomized control trials, and they did not show a reduction in mortality. They did show that chest X-ray can detect cancer early, in earlier stages, and has better survival rates. But since there were no differences in mortality between control arm and the chest X-ray screening arm, it was assumed that chest X-ray was detecting overdiagnosed cancers, cancers that, if left alone, would not cause the demise of the patient. And even though that was not a pre-test endpoint, it was assumed that that was the case. And you can see that from 1986, when that Mayo lung trial was published, up until the year 2000 or 1999, there was basically no interest in lung cancer. And it was in 1999 when things changed dramatically. And it did, thanks to Professor Claudia Henschke and Professor David Yankelevich, leaders of the ILCAP group. Back then it was called LCAP because it was focused in New York. It's the Early Lung Cancer Action Program. And what they did, this is the paper that they published in 1999 in Lancet, they recruited 1,000 individuals with a heavy smoking history, 45 pack years of median history, 67 years of age, and they all underwent a baseline low-dose CT. Low dose means low radiation dose computed tomography, and a chest X-ray. And then they repeated that 1 year later. Here I'm just showing the results of the baseline screening, and that's what was published in Lancet. And the paper, this is the paper that probably has changed the story completely. You can see down below that in 233 individuals, the low-dose CT detected non-calcified nodules. Those are nodules that are suspicious for lung cancer. Chest X-ray only detected it in 7% of the individuals. Of these 233, 27 ended up having lung cancer. Only 7 of those cancers were detected by chest X-ray. But look at the stage distribution of those cancers that were detected. 85% were detected in stage 1. 85% of these 27 cancers, I'm sorry, in the low-dose CT group. Now, this is an incredible statistic, which was completely opposite of what was seen back then and still now in any hospital or any series that does not apply lung cancer screening. Today, 80 or more % of individuals with lung cancer are diagnosed in late stages. So that was 1999. There was a lot of discussion back then about that being enough to recommend lung cancer screening or not. The LCAP group thought it was, but many other people thought it wasn't. And the NCI, after discussions with people from the LCAP, sat down and designed, with the help of LCAP, a large randomized control trial called the National Lung Screening Trial, the NLST, which you've probably all heard about, which was published 11 years afterwards. During that time, no screening was performed because it was thought that we needed a randomized control trial with a control arm to demonstrate that that stage shift that we had observed in LCAP actually was translated into a reduction in mortality. At the same time, the LCAP group organized an international consortium inviting centers that would do lung cancer screening following a common protocol. And this was called International LCAP. And this is when I met Professor Henschke and Professor Yankelevich, and we joined this consortium back in year 2000 and have been working with them very closely ever since. Up to 80 centers joined this consortium from 10 different countries. We all use a common screening protocol, but it's a protocol that changes very frequently. It's very flexible. You meet every 6 months. We've had more than 40-some meetings of this consortium, and we change the protocol as data is analyzed, improving management of nodules, improving many other issues related to screening. We all do yearly screenings, or we invite our participants to undergo yearly screening. We do not have a control arm. Everybody undergoes screening. We all use low radiation dose computed tomography, and we use the protocol, which is part of a large management system, which allows for scheduling, for reporting, for many other things that really is becoming almost like an independent or part of the electronic medical record, but it's independent management system of patients. And that also allows to gather an enormous amount of data in a huge central database. And it has allowed us to analyze many, many aspects related to lung cancer screening and to therefore publish also many, many papers. Perhaps the most important one is this one published back in 2006. And basically we focused here on the survival of patients with stage 1 lung cancer diagnosed. This slide summarizes the cohort that was analyzed. After 31,000 individuals were screened once, that's the baseline screening, and some of them returned for annual screenings, those are the 27,000 that you see on the right. We gathered the information from all these screenings and came up with this data. In the baseline round of screening, 4,000 individuals, 13%, had a non-calcified nodule of 5 millimeters or more. 405 cancers were diagnosed as a result of a workup of those nodules. And I have to clarify here, the workup of a nodule doesn't mean a biopsy right away. The protocol includes periodic follow-up with more low-dose CTs to look for growth of nodules. And I'll show you later a little bit more about this. So 1.3% prevalence of cancer in those baseline screenings. And in the annual screenings, 5%, 1,400 individuals had a new non-calcified nodule, and 74 cancers were diagnosed as a result of that. In total, 484 cancers. They were all grouped together because when we analyzed both differently, the data, there was no difference between them. So we analyzed the group as a whole, and again, 85% of these cancers are diagnosed in stage 1. Incredible statistics. And look at the survival, long-term survival, 10-year survival rate of these 484 cancers. That's 80%. When we focus on individuals who had a stage 1 cancer and were resected before a month from the diagnosis had elapsed, the survival rate at 10 years is greater than 90%. But in any case, 80% of all the cancers, this includes interval cancers and cancers in more advanced stages, have a 10-year survival rate of more than 80%. That was 2006. Still, in the United States, awaiting the LST, and in Europe, awaiting other trials, no lung cancer screening efforts started anywhere, except for some places in Asia. Finally, in 2011, the National Lung Screening Trial data was published. This study, 50,000 individuals, randomized to 2 groups. The individuals had to be 55 years of age or more, up to 74, and had to have smoked at least 30 pack years of cigarettes. For former smokers, they had quit within 15 years prior to entering into the study. The 2 groups were, one, the screening intervention group. They applied an annual low-dose CT at time 0 or baseline at year 1 and year 2. And the control arm, they used chest X-ray. It wasn't a true control arm. They did screening with chest X-ray. So it was really comparing screening with low-dose CT to screening with chest X-ray. The endpoint, the primary endpoint, was a 20% reduction in lung cancer-specific mortality after 9 to 10 years of follow-up. Now, at 6 years of follow-up, the NCI had to stop the trial because that primary endpoint had been achieved already, 20% reduction in mortality. And in addition, there was a 7% reduction in all-cause mortality, mostly due to the large reduction in lung cancer mortality. This is the Kaplan curve showing the accumulation of cancer deaths in both groups. And you can see in the blue graph, which represents individuals who underwent screening with chest X-ray, and in the orange, you can see individuals who underwent screening with low-dose CT. And at the end, you can see the difference in deaths, which is the 20% reduction. Now, you would ask yourself probably, why, if in ILCAP we're seeing an 85% rate of stage 1 disease when we do screening, why are, or an 80% 10-year survival rate, why is there only a 20% reduction in mortality? That's probably due to the design of the study. And I want to try to summarize it in this slide, if I may. If you look in the x-axis, we see the years of screening. Year 0, baseline, year 1, and year 2. That's it. There was no more screening done in the LST. After that, patients were followed up for initially, the intent was to go up to 9 years, but it was stopped at 6.5 years, more or less. Now, look at the distribution of cancers in these two periods. In the first period, with the 3 rounds of screening, 64% of cancers were diagnosed in stage 1 to 2. And we're talking about 679 cancers. However, in the second part, in the follow-up years, 361 more cancers were diagnosed, almost a third of the entire number of cancers, and 62% were diagnosed in stage 3 and 4. So obviously that not favorable staging in the second part had to dilute the beneficial effects of the early screening, and thus we only see a 20% reduction. However, in spite of that, we could say we see a 20% reduction, and in spite of the fact that the comparator was a chest X-ray screening, not no screening whatsoever. In 2013, thanks to that data, the USPSTF finally recommended, with a grade B, annual screening for low-dose for lung cancer with low-dose CT, and used the criteria that the LST had used to select patients as the recommended criteria for selection of candidates who should undergo screening. Age 55 through 80, they increased the age from 74 to 80, the older limit. History of heavy smoking, 30-pack years, and current or former smokers, but those who have quit within the last 15 years. That was 2011. Amazingly, still today in the United States, lung cancer screening is even though it is offered, it's being implemented very, very slowly. The uptake is very slow. And in Europe, it's non-existent. Still, we do not do screening, except for one country that started during 2020, which was Croatia. One of the reasons why Europe has not started screening is because authorities, experts said, and I'm not kidding, that the American study was not enough. We needed a European study. And the Nelson was being conducted, so we had to wait for the Nelson, which is a smaller randomized controlled trial, but nonetheless, it is a randomized controlled trial, pretty well designed, and here are the data, also published in the New England Journal of Medicine in the year 2020, although the data was presented at a world conference, a lung cancer world conference in 2018. 15,000 individuals, similar entry criteria, a little younger and a little less smoking history. And 4 rounds of screening were offered versus no screening. Here we have a true control group. The screening was done at years 0, 1, 3, and then 5.5 years. And the main objective was 25% reduction in lung cancer specific mortality at 10 years. And that was achieved significantly. In males, there was a 26% reduction in mortality at year 10, and in women, 40% reduction. Now, interestingly, this was achieved also at year 8 after follow-up, but the data was not presented until the end of the 10-year follow-up, and something that might have helped us to know a little, to help us a little earlier. And finally, I'm just going to mention very quickly one last study that was just published, the multicentric Italian lung cancer study, which is another randomized controlled trial, much smaller, 4,000 individuals. I'm not going to go into the details of the design, but also showing a 39% reduction in lung cancer mortality when you use low-dose CT versus no screening, no chest X-ray, nothing, just usual care. What's interesting of this study is that they did many more rounds of screening, probably up to in a median of 6 to 7. And when you look at the data after the 5 first years, you exclude the mortality or the deaths in the first 5 years, the reduction in mortality starts growing quite quickly. And at 10 years, there's a 58% risk reduction in lung cancer mortality when you screen with low-dose CT. So to summarize this first part of the talk, yearly lung cancer screening with low-dose CT results in a significant stage shift and improved survival rates, and in a significant reduction in cancer-specific mortality rates. Screening for more years has been shown in these three studies, randomized studies, that as you screen more times, you get better or greater reductions in mortality. However, we still have many barriers to implement low-dose CT screening, especially in Europe, as I said before. In the United States, it is picking up slowly, but it is picking up. And hopefully that's one of the things we will be working on in the near future with you when I move to New York. What are the problems? I'm listing here just a few. There's some others, but these are the problems that come up in all of the discussions in many different places. Radiation has been settled quite clearly today. The radiation that we use for screening is equivalent or even lower than mammography. And with newer technologies that are coming up, there's the ultra low dose CT, which uses radiation similar to a chest X-ray. Cost-effectiveness, that's been an issue, but has been clearly shown that when screening is done in a correct fashion, it is cost-effective. The NLST trial, using the 20% mortality reduction as an endpoint, found that a cost of a quality-adjusted life year saved is $81,000. However, when you apply better mortality reductions, or you apply ILCAP data, for instance, these numbers start dropping quite significantly. In the UK, a study was done. They have a randomized controlled trial pilot study, and they analyzed their costs, and obviously the costs were significantly lower and showed very appropriate or acceptable cost-effectiveness ratios for lung cancer screening. Overdiagnosis is a big issue. It has been a big issue in terms of discussion. I can start with the conclusion: it's not a big issue in lung cancer screening. And I want to try to prove it to you with this one slide. On top and on the left in the top graph, you see the cases per 1,000 person years of lung cancer in the Nelson, the European trial. And you can see in the blue line, right after screening at time 0, obviously the number of cancers in the screening group increased significantly. In red, we see the number of cancers that start appearing in the control arm. If you would stop screening here at 5 years after initiation or recruitment, you would have a huge difference in the number of cancers. You would think that there are a lot more cancers in the screening group than in the control group, and there will be a mortality improvement. However, you could say that you're just detecting a lot more cancers, and therefore you cannot really assume that it's due to lung cancer screening. As we get further down the line, these lines are starting to converge, and the mortality difference is clearly becoming better. And today, we know that 10 years after randomization, the difference in number of cancers in both groups was 40 cases. That amounts to 20% overdiagnosis or risk of overdiagnosis. But 1 year later, that drops to 8.9%, only 18 cases. And I'm sure that as we get more data at 15 years, the numbers are going to be equal probably, as has happened with the NLST. In the NLST today, after 10, 12 years of follow-up, the number of cancers in both groups is identical. So overdiagnosis is not really a big issue. Now, there is a risk of overdiagnosis if we don't know how to manage certain findings. And this is a study done by Yankelevich, by the LCAP group, looking at non-solid nodules. Here on the left in the CT scan, you can see a ground glass density. We call these non-solid nodules. And initially, when we started doing screening, we would consider these nodules. And if they grew, we would resect them. And they were part of the lung cancer diagnosis cohorts. Now what we do is we follow them because we know that these are not invasive tumors. And it's shown very clearly in this case. The middle CT is 2 years after the first one, and it's the same, it hasn't changed. Now, 9 years later, you start seeing a much denser area within the non-solid nodule. That's developing what we call in our protocol a part solid component. That was resected, and that part solid component does represent invasive adenocarcinoma. So essentially, we've learned how to deal with these nodules that could be considered overdiagnosed, but we know how to follow them, and unless they develop a part solid component, we don't resect them. Therefore, we're not over-treating patients, which is the most important part of the overdiagnosis. This is a summary of the non-solid nodules of the ILCAP cohort. When we had 57,000 participants, 4.2% had a non-solid nodule. 26% of them resolved after you followed them up for a few months. And 73 ended up being cancers, where 3.1% of all the non-solid nodules were cancers. In the annual low-dose CT, you can see that there's less number of incidence of non-solid nodules. They resolve more, 66%, and then the proportion of nodules that end up being cancer is similar, about 2.2%. But again, we've learned how to deal with these. And when we studied these, all were stage 1 adenocarcinomas when we resected them. The survival time at 78 months is 100%. That probably means that some of those might have not needed to be resected, but in any case, we followed them for a median time of 19 months. We did not intervene immediately. We avoid over-treating patients initially. And this is important because there's a risk if you detect many positive nodules in the CT scan, there's a risk that we would start doing interventions unnecessarily. And I'll talk a little bit more about this later on. This is a review of all the studies published with non-solid nodules done by Rowena Yip from the ILCAP group at Mount Sinai, and basically showing that after analyzing 712 cancers that presented with as a non-solid nodule, 0.1% had lymph node metastasis, and again, the long-term survival, 100%. False positives. This is another issue that has been debated quite a bit. Look at the criteria that we use to consider a low-dose CT positive. The LST used 4 millimeters as a threshold. If you have a solid nodule that is 4 millimeters or more, that low-dose CT is considered positive. And in the baseline round, 27% of their screenings were positive. So going back to what I said before, imagine doing biopsies on these 27%, if only less than 5% of these are cancers, and that's the case. The problem is that what people are saying, or what is said around there, is that 27% of these positives, 90-some% of them are not cancer. Therefore, you hear people talk about a 90-some% false positive rate, and that is incorrect. The ILCAP group established 5 millimeters as the threshold. 13% were positive in the baseline round. After we reanalyzed our data retrospectively, we realized that if we increased that threshold to 6 millimeters, we dropped the positives, obviously, to 10%, and we don't miss any of the cancers. And since then, we have been doing that. That was published, and all the other, by the way, organizations have established 6 millimeters as the threshold after that. The Nelson trial in Europe used a completely different definition. They defined the positive anything 10 millimeters or more. They actually used volume, but it was equivalent to 10 millimeters or more. They didn't consider anything less than that negative. There was an intermediate group between 10 millimeters and 4 or 5 that was considered intermediate or indeterminate. They needed a new low-dose CT 3 months later. If there was growth, it was considered a positive. If there was no growth, it was considered a negative. In any case, you can see that the number of positives in this study is much lower. And why, again, is this important? You have to be able to balance the detection of nodules that are not cancer and that might undergo surgery with curability of lung cancer. If we try to avoid unnecessary surgeries on benign lesions to completely, to drop that rate to zero, we're going to start diagnosing many more cancers in advanced stages. So we have to find that balance. And I think this study by Raja Flores, thoracic surgeon at Mount Sinai, shows this very nicely after analyzing the ILCAP cohort. 69,000 individuals who underwent 69,000 rounds of screening, both baseline and annual. 492 individuals underwent surgery. That's 0.7% of the population. 89% of those surgeries ended up being lung cancer, and 11% were benign lesions. So 11% of the surgeries done in LCAP were, quote, unnecessary, unquote, because they were benign. They ended up being benign lesions. Most of these interventions for benign lesions are not lobectomies or sublobar resections. So again, we have to find that equilibrium. What is acceptable? Is 11% acceptable? If you go back to the historical series, you'll see some series where they operated on nodules before lung cancer was even talked about, and 50% of the nodules resected were benign. So that has not been settled. There's a lot of discussion about this. These are the different rates of unnecessary surgeries in the different cohorts, ILCAP and LST, the Italian cohort, our cohort in Spain, which is part of ILCAP, around 5 to 10%. The LST is higher because the LST did not use a diagnostic regimen once you had a nodule detected. They allowed each physician, each participating physician to decide based on their clinical experience. In all of the rest of the trials, there was a protocol that called for different interventions depending on the characteristics of the nodule. And that's why these surgeries, the percentage of surgeries is lower. Going back to the selection of candidates, I already showed you what the USPSTF recommends. I wanted to show you that these are probably not adequate. This is another point of contention. If we apply those USPSTF criteria to our cohort here in Pamplona in Spain, we admit people into the screening program with a younger age, 40 years or more, who have smoked 10-pack years or more. So we're very flexible. We admit many, many people into the program. If we then go ahead and apply the USPSTF criteria retrospectively, 40% of the cancers that we have diagnosed in our screening program would not have been eligible for lung cancer screening. We did this study in collaboration with Pittsburgh, with David Wilson from Pittsburgh in their PLUS study, and 25% of their cancers would not have been eligible. They used higher risk population. The age was higher and the smoking requirements were also higher. But still, 25% would not have been eligible. There are many series out there, some looking at SEER and others, that suggested up to 50% of resected lung cancers outside of screening would not meet USPSTF criteria. And then there's a recent study by Pasquinelli showing that in Chicago, that their USPSTF criteria also results in greater racial disparities. They applied USPSTF criteria to their group of lung cancer patients in their hospital, and there were a significant number or higher number of cancers in African Americans that would not have been candidates for lung cancer screening as compared to whites. So because of this, many, many groups are working on different risk models to help select individuals that should undergo screening. This has not been settled, and you can see why in this slide. This also was done by Rowena Yip from ILCAP. She looked at the four most common or most famous, I should say, models that have been published and applied them to the ILCAP cohort. And you can see that the behavior of all these models is not stellar. It's AUCs below 70% in all cases. So a lot of work has to be done still to find the right criteria to select patients who should undergo screening. We have worked a lot on emphysema as a criteria that might help. And I'm not going to go into that deeply, but I am going to show you some work that we've done regarding emphysema. And more related to this concept that James Molshine brought up in this article that I recommend, thinking about lung cancer screening, or better said, low-dose CT screening as a one screening deal for ischemic heart disease, lung cancer, and chronic obstructive pulmonary disease. Remember the three first causes of disability years, adjusted lost years. I'm going to show you some about our data on COPD and emphysema. This is our cohort in Pamplona, represented by this non-proportional Venn diagram. We have three groups of individuals: healthy smokers. These are individuals who have not have smoked, but do not have COPD and or emphysema. And then two groups, one with emphysema and one with COPD, some overlap among them. You can see that emphysema and COPD represents almost half of the population. And each little human figure that I'm showing here represents a patient with lung cancer. And you can see that 81% of the cancers in our cohort are diagnosed in individuals who have either COPD or emphysema. When we did a multivariate analysis of this, we realized that after adjusting for age, sex, and PAC years, known predictors of risk for lung cancer, emphysema stood out as an independent predictor of risk for lung cancer. If you have emphysema, your risk of having lung cancer is 2.5 times greater. COPD, which was significant in a univariate analysis, was not when we had included it in a model with emphysema. So suggesting that emphysema is a more powerful biomarker as a predictor of risk for lung cancer. The Pittsburgh group, David Wilson, did an identical study. By the way, that study that I just showed was the first one to show this phenomenon. David Wilson published this a few months later, and identical results. Emphysema, when adjusted for age, sex, and PAC years, stands out as an independent predictor of risk for lung cancer. We looked at the LCAP cohort in New York, and the presence of emphysema. When I say presence of emphysema, I mean that the radiologist sees it on the CT scan. It's not a software detected or quantified emphysema. It's emphysema that we can see easily on the CT scan. And when that happens, individuals, obviously, you can predict that the patient is going to die. This is risk of death from COPD, but also from lung cancer. So clearly, emphysema is showing here that is a very strong, powerful marker of risk of lung cancer. Now, I think this study that we did with Professor Henschke kind of settles this issue for good. We, in our cohort, in the ILCAP cohort, have a large group of individuals who have not smoked, but were exposed to secondhand smoke. And we recruited these under a grant by FAMRI. The Flight Attendant Association was interested in secondhand smoke. And here we show some interesting data. And later on, I'm going to show you some other data related to coronary artery disease. But here we divide the groups into individuals with all our entire cohort, ILCAP cohort, patients without emphysema, and patients with emphysema on the CT scan. Current smokers and former smokers, you can tell that the presence of emphysema, the prevalence of lung cancer increases by 80% or 70%. In never smokers or secondhand smokers, the prevalence of lung cancer without emphysema is very low. But look what happens in those who have a little bit of emphysema. The prevalence is equal to that of in smokers, both current and former. That is very interesting. So again, emphysema clearly showing it is a powerful predictor of lung cancer risk. And why is it important? Look at the prevalence of emphysema in different lung cancer screening cohorts. On your right, anywhere from 29 to 40% of individuals who enter a screening program will have emphysema on their CT scan. And if you look at, if you have spirometry data, which we do and some others as well, you can see that anywhere between 15 to 40% of individuals have COPD. And they don't overlap necessarily completely. Some have both, but there are many people who have only COPD and many people who only have emphysema. And in our cohort in particular, this represents almost half of the population. We also looked at coronary artery disease in ILCAP. And this study was done by Dr. Shemesh, a cardiologist from Israel, who looked at the data and first of all developed a score, an ordinal score of coronary artery using low-dose CT, which is a non-gated CT, and found that it correlates very well with gated, typical gated CT scan scores of coronary artery disease or coronary calcification, I should say. So here he looked at this ordinal score in a low-dose CT in our population. The score goes anywhere from 0 to 12. And according to that score, divided the population into two groups, those with a score of greater than 4 or less than 4. And you can see clearly a difference in mortality from cardiovascular disease. Going beyond that, David Yankelevich again analyzed the cohort of secondhand smokers. Here on the left, you have the questionnaire that we use to quantify the amount of secondhand smoking exposure. Now on the right, you can see how the ILCAP cohort was, or the ILCAP secondhand smoker cohort was divided depending on the intensity of the exposure, anywhere from minimal to more than minimal. And that's how we're going to leave it. Low, moderate, and high put together into more than minimal. And look at the prevalence of coronary calcium in men and women at all ages when there's more than minimal secondhand smoke exposure. Coronary calcium scores clearly superior to those who have minimal secondhand exposure. Thus, we're showing that with one test, the low-dose CT, we can probably do a health check of, I'm not talking about lung cancer screening anymore, a health check of thoracic tobacco-related diseases, coronary vascular disease, COPD-Emphysema, and lung cancer. This is something that we're starting to talk about it more and more, and you can start seeing how this might be very helpful for workup or managing our patients, especially from a primary care point of view, since the prevalence of smoking is so high still in many places in the world. So I'm going to end up with a couple of slides on the future, and it's really many other areas that are going to come out in the near future and in long-term future. Artificial intelligence is one of the strongest ones. It's going to be helpful for detecting nodules better, for diagnosing nodules, for diagnosing COPD on a CT scan without spirometry, et cetera, et cetera. Lung cancer screening for secondhand smokers, I've already talked to you a little bit about that. That's going to probably be talked about more and more. Ultra low dose CT, improvement in 3D volume studies of nodules that needs to be done, and of course implementation. We are way behind where we should be in implementing lung cancer screening, and hopefully that will change in the coming months and years. And with that, I thank you very much.
Thank you very much, Dr. Zulueta. That's a great talk. Now we're going to open the floor for questions. I remember that if you're going to pose a question, identify yourself, which department you work in, what kind of patients that you see. We already have one question on the chat, and it's relevant to one of the slides you just showed regarding their calcium score. So Melissa Wiener is saying that, when she orders a low-dose CT scan, she gets, information that she didn't ask, which is a calcium score. And what are your thoughts about getting unrequested results when screening for something unrelated?
Yes.
Norma Braun, I have several questions. One is, was there any attempt to look at the relation?
Norma, we're addressing a question from Dr. Wiener, and just to remind everybody, and particularly helpful today with Dr. Zulueta, to mention where you're from. Melissa Wiener is one of our really wonderful HIV specialists in our infectious diseases division.
Great. Yeah, thank you. That question is very relevant, because this is a problem that we find ever since we started, where all these incidental findings that initially we didn't know what to do, coronary calcium being one of them. Now we've learned. In my practice, when I see coronary calcium, I'm not an expert in coronary artery disease, but it's enough to trigger some interest in it, and to submit, send patients to to the cardiologist if it's enough. We have follow-up over years that we can see if it's becoming more of a problem. So, and we have to develop those criteria much better, obviously. But that is a big issue. You're going to be finding on reports many things that slowly we're going to learn what to do with them. We know already a lot, but a lot more has to be done. Pulmonary fibrosis is another one that I didn't mention, but that's becoming a common issue.
Go ahead, Norma.
Okay. I wanted to ask whether or not there was any attempt at correlating, especially in China, the degree of air pollution and its cofactor as a carcinogenic exposure, because that's clearly a potential risk for certain occupations as well because of the pollution. Another question was was there a dropout rate in any of the studies that could change the statistics to some extent, and to what level? And the last question is, how long do you keep doing it? It sounds like from what you said, 11 years is the limit for how long you keep looking for this. And then when do comorbidities override the need to screen any further? Thank you.
Pollution, that's a big issue, especially in Asia. They're doing a lot of screening in non-smokers. They've been doing this for years in Japan, many years before we even started talking about screening in the Western world. So yes, that is a big issue. We have not addressed that in ILCAP or in the other studies that I mentioned, that's for sure. But that is something very important. And you know, radon exposure. How is that going to play? Mm-hmm. All these things will have to be addressed, no doubt. Dropout in the randomized controlled trials was very low. These were trials that had very good compliance, and there was very little contamination in the control arms. So those results are pretty reliable. There is dropout in screening. In our cohort in Spain, for instance, I work at a private center. After the first few years, patients would have to pay for their screening if they wanted to continue. And we saw a very significant dropout, obviously, down to less than 60% of compliance. How long to screen? The recommendation is to do it yearly up until age 80. Some recommend 74. It really depends more on what vital risk you have, or you mentioned the comorbidities. How long do you expect to live at the time you're going to undergo screening? Obviously, if you have many comorbidities and you're not going to be able to undergo surgery, there's no point in doing lung cancer screening. Although new treatments are coming up that might not require surgery, SBRT, things like that might change. These are not criteria that are set in stone for sure. At least we don't know the data to be able to defend one or the other. But today, the recommendation is to do yearly screenings for a long time, much more than 11 years, up to 80 years of age, for instance. I don't know. It's an arbitrary number.
We have another question from Dr. Steiger from the Pulmonary Critical Care and Sleep Medicine Department.
David, if I can so Dr. Braun, Dr. Zulueta, just in case you don't know, she's really one of our most esteemed pulmonary faculty with an interest and wonderful expertise in motor disorders and their contribution to restrictive diseases. Go ahead, David.
Yeah, so Dr. Steiger from the Pulmonary Critical Care and Sleep Medicine Department, he's asking, what are your opinions on broadening lung cancer screening eligibility criteria as per the National Comprehensive Cancer Network, including, familial history of lung cancer, occupational risk, prior personal history of cancer, COPD, etc. In view of low lung cancer screening rates, should we be proactively recruiting eligible patients by screening, EHR and reaching out to patients, since many of them do not have primary care physicians?
Yeah, well, wow, in a question, David has summarized the current problems of lung cancer screening. It definitely, I agree with the premise behind the question. We have to expand entry criteria, no doubt. We have defending in our place allowing anybody to undergo at least a baseline screening, and then using that information that you obtain on that screening, like for instance, the presence of emphysema, COPD if you've done a spirometry, comorbidities, family history, etc., to recommend annual screenings or not. And by doing that, we have shown and published that you can actually improve on the number of screenings needed to be performed in order to diagnose lung cancer. Or in other words, you would improve cost effectiveness without missing cancers. We have to reach out to many, many people who are not going to be eligible for lung cancer if we restrict the criteria to what USPSTF is recommending today. The NCCN does have an expanded criteria, but again, I still think it falls short of where it should be. I think we have to work on how to reach out to many more people who would not be eligible if we restrict the criteria to what's recommended today.
Thank you, Dr.
Javier, just following up on your comments about, and thank you for a wonderful talk. Really just loved learning so much. I wonder, is there anything for us to learn in the United States from your experience in Western Europe in terms of what you described as the poor uptake in screening?
Well, considering that in Western Europe, there's no screening going on whatsoever, I hope you don't learn much, at least.
Taken.
The only country, as I mentioned briefly, that has started screening is Croatia, and they've started it following ILCAP's model. I think ILCAP is really the model to follow because it is very flexible in terms of entry, and once you enter, the protocol is so well designed and studied that there's very low risk of doing excessive harm or probably any harm, excessive screening, radiation, surgeries, etc. How to implement it and how to reach out to the patients, I don't know. I still don't know how the U.S. system works that well. I think I'm going to learn very soon. Here in Spain, for instance, there's no information on tobacco history in the electronic record available to primary care physicians. So primary care physicians would have to question each individual about smoking. And if 30-pack years is a strict criteria, then how are we going to reach out? It's impossible. That's why we, our group, defends allowing anybody who has smoked, voluntarily, even if they lie, it doesn't matter. One low-dose CT scan is going to do very, very little harm, especially if we start enhancing the concept of screening to thoracic diseases in general. I think it's probably going to become eventually, someday, a routine test, as we today do other routine tests when we evaluate our patients for the first time.
I think we have just one more question from Dr. O'Sullivan. She's also faculty for pulmonary medicine, and she also leads the smoking cessation clinic. She's asking, how do you see smoking cessation being strengthened as part of the screening process?
Dr. Osorio, I apologize for not mentioning smoking cessation. I did intend to do it, and I didn't, and it's very, very, very important. It's key, actually. I think it makes no sense to offer lung cancer screening if you're not offering smoking cessation at the same time. I'm glad you asked this question because I had forgotten, I neglected to say that. Yes, and it's been shown that cost effectiveness improves quite a bit if you apply smoking cessation. Obviously, smoking cessation, we know the effect of it takes many, many years to translate into reductions of lung cancer incidence. But without smoking, we wouldn't be here. So talking about this, so yes, obviously we have to keep on working on smoking cessation and incorporate smoking cessation into lung cancer screening programs. They cannot go, lung cancer screening program without smoking cessation makes no sense.
Thank you, Dr. Zulueta, and welcome. We're so pleased that you'll be coming to join us. I I've worked with Dr. Henschke very peripherally, but my concern is always that this gets the importance and actually, I guess, the money to provide not just a brief counseling, but prescription writing and putting some real meat into the effort. And so that's my thought. And again, thank you so much.
Well, I'm looking forward to working with you on this. I think we have to do that.
Dr. Zulueta, thanks so much again for a wonderful talk and kicking off our spring semester.
I wanted to ask a question.
Sure, Jerry. Dr. Torino.
Yes,
absolutely.
Hi. Given the limitations of low-dose CT, as you well outlined, it's a lovely talk, what are the prospects for a chemical biomarker for lung cancers?
Yeah, that's wow. You know, I would say that for every dollar that is, and I'm just making this up, I'm just guessing, but for every dollar that is put into low-dose CT research, probably, I don't know, 1,000, 10,000, $1 million are put into biomarker studies, looking for that chemical marker. There are many companies and institutions, academic institutions, looking for the biomarkers. Today, yet there hasn't been one, and they're not even close. I think that will come someday. Maybe not as a standalone test, maybe in combination with low-dose CT to help select patients, to help maybe select risk of lung cancer and like pre-selection for low-dose CT. That is a very hot topic, but not much more available yet today.
Thanks so much. Yeah.
Dr. Zulueta, thanks again for a wonderful talk. We're nothing but excited to contemplate your arrival in the next month or so. And in the meantime, we wish you all the best, and that to your colleagues as well as you battle through this really challenging time in the COVID pandemic. Thank you again.
Thank you all very much, and I'm really looking forward to meeting you in person.